Okay, in this section we'll look at the different special senses, and also know that I have posted several videos on special senses that I recommend you take a look at. Most of them are 3D animations, and they're really good to help understand more about what's going on with our special senses. Okay, we'll start with the eye. The eyes are considered the most complicated of our sensory and requires the most learning. About 70% of all sensory receptors are located in the eyes. We have millions of nerve fibers in there. The optic tract is what carries information from the eyes to the brain to the occipital lobe. Okay, know these parts. Know the pupil, the iris, sclera, the lacrimal gland and lacrimal ducts. These are the tear ducts and where your tears are formed. Okay, this is the lacrimal sac and nasolacrimal duct. We have the upper eyelid and lower eyelid, and the white of the eye is the sclera. Okay, the eye is about 1 inch in diameter, and you only see about 1/6 of it. The rest of it is recessed into the skull to its bony orbit, and that, along with fat that surrounds it, helps protect and cushion the eye. Some accessory eye structures are considered the extrinsic eye muscles, the eyelids, the eyelashes, the conjunctiva, and the lacrimal apparatus. The conjunctiva is a membrane that lines the eyelids and covers part of the eyeball. It secretes a mucus to help lubricate the eye. If this area gets inflamed, it's conjunctivitis, in lay terms the pink eye, and it is contagious, and it could be either bacteria or viral that causes it. Okay, the lacrimal apparatus consists of the lacrimal glands, the lacrimal canals, the lacrimal sac, and the nasolacrimal duct. So tears, or lacrimal secretions in fancier terms, they contain antibodies and lysosomes, which are enzymes that help destroy bacteria, basically a type of Pac-Man. The nasal cavity mucosa is continuous with the lacrimal duct system, and because of this, colds, nasal inflammation cause the lacrimal mucosa to become inflamed, which can impair drainage of the tears from the eyes. Okay, here's a lateral view of the eye. So, the bone's been removed. You can see the nose area there, so that's the medial side, and we're looking at the lateral. And this is showing you the some of the eye muscles. Okay, so do review your eye muscles. There's gonna be some test questions on them. It's part of cranial nerve. We covered it in skeletal muscle, and we've been revisiting it with nervous system and special senses. So just know your formula, LR6, SO4, R3, and remember what they innervate and what the actions of the muscles do for the eye. Okay, a lateral view of the eye. We're seeing at this part the cornea. And I do have a really good video posted on this that shows a 3D animation of the eye, goes over all these parts, so please check that out. Here's the cornea of the eye and the lens. the ciliary body, the ciliary zonules. This is what contracts to help the lens bulge or relax. You can see a silhouette of the iris. The lens, to some degree, is the division point between the anterior part of the eye and the posterior part of the eye. The anterior part of the eye has the aqueous humor. Humor is a fancy word for fluid. So there's fluid in the front of the eye called aqueous humor, and fluid in the back of the eye, which is behind the lens and on back. So all this area is the vitreous humor. Okay, so there's fluid in the eye. Now, some people, right here with the canal of Schlemm, this canal can get clogged, and it can inhibit adequate drainage from the eye, so you can start to get intraocular pressure. So there is some manual techniques that you can do to get the eye circulation moving again to reduce pressure. If that does not take place, over time it can lead to sclerosis of the eye, hardening of the eye, glaucoma. Okay, we also have, so the outer part is the sclera, so that's the white of the eye. Then the next layer in, we see the choroid. And then the next layer in, we see the retina. Okay, so lots of, you can see the retina in here, all that stuff. Here's the fovea centralis and the optic nerve with the blood vessels coming in, and there's the optic disc. Okay, the pupil is the opening to the eye. So just went over those tunics, the sclera, the choroid, and the retina. Okay, the cornea is a transparent window through which light enters, and that 3D video of the eye shows a really good picture of this. So please check that out. It does have nerve endings, so it is sensitive to irritation, pain. You know, if something happens to it, you're going to feel that, so there's pain fibers there. It does have the ability to regenerate if damaged, and there's some reflex abilities in there. One of the reasons why, if you get something in your eye, you know, you get that blinking and that tearing and all that stuff that can happen. Also, it can be transplanted from one person to another without rejection because there's no vascular supply, which means it's out of the reach of the immune system. Okay, the choroid, which is here, so the choroid. It's rich with blood. It's darkly pigmented so light will not scatter around the eye. And anteriorly it tapers into the ciliary body, which the lens is attached to. So let's check that out. As you can follow it, there it is, ciliary body, which is connected to the ciliary zonules, which is connected to the lens, which when contracted helps, or when this moves, it contracts the lens. Okay, the pupil is surrounded by the pigmented iris. The hole in the middle of the iris is the opening to the eye that we call the pupil. It's where light passes through. It is smooth muscle fibers, so when light enters the eye, or enough light enters the eye, the pupils will constrict. In the absence of light, the pupils will dilate. Okay, the retina is the innermost sensory tunic of the eye. It tapers anteriorly to the ciliary body, and it contains millions of receptors, including the rods and the cones. Now, don't confuse these. I see it confused often on tests. The rods are your night receptors. So when the sun goes down, well, better said, just in a dim or dark room, your pupils will dilate and the rods become more active and the cones become a little bit less active, which gives you your so-called night vision. And to give you a more specific visual of this, I'm sure you all have been in a dark room or dim, and someone comes in and turns the lights on, and it takes that minute to adapt to the bright light, and you're kind of like, man, come on, and you just get used to it, once the lights are on, and then they shut them off real quick on you, and for a moment the room is pretty much pitch black. But if you focus and give it a minute, all of a sudden your eyes start to adapt to the dark, and then you can see better. That is because you're activating the rods. Those are your night receptors. Okay. Also, the reason why people who go camping, military, and the like, they'll have these red headlamps or red flashlights. The red filter is designed to spare the rods. So picture this, okay, you're camping and it's dark out, it's nighttime, and everybody's wearing a red headlamp, and by doing that they are sparing your night vision, which means you keep your night vision. But then somebody comes along and shines a white light in your eyes, and everybody goes, man, so you get that temporary spot blindness, and it took away your active rods, switched them over to cones, which is the color and day receptors, and then they take the white light away, and you're left with that, temporary night blindness. But if someone were to shine the red light at you, you don't lose that night vision, that adaptation that you have now acquired for seeing in the dark, because that's the purpose of the red lights. If you ever wondered why people camp and they have these red lights, or the headlamp can toggle back and forth between white light and red light, that's why. So the rods and cones are photoreceptors, which means they respond to light, and they hit bipolar cells. Okay, so the specialized nerves in the eye are called bipolar neurons or bipolar cells. And then it hits the ganglion cells, and then to the optic nerve, which is cranial nerve 2, and then it goes to the optic cortex, which is in the occiput. Okay, these photoreceptors are all over the retina, except for where the optic disc is, because that's where the optic nerve comes in the blood vessels. So that is our physiological blind spot. There's no photoreceptors there. Okay, so building on the physiological blind spot, Dr. Carrick did some research on changes in brain function and the adjustment of the cervical spine. So this is where we're moving cervical bones back into place, which uninfringes upon nerve activity. So in other words, if bones move out of place, you get neurological inhibition. Okay? If you realign it, you get the nerve function back. So what he did is he mapped out the physiological blind spot, which is believed to be a cortical perceptual map or reflexation of synaptic summation of the contralateral thalamus and the visual cortex were tested. Adjustments of the cervical spine will show changes in brain function indicated on the blind spot perceptual map. They tested 500 people, and 94.6, the contralateral adjustment worked, okay? So at this point, if you're like, what the heck are you talking about? Here's what we're talking about. So a person was standing about 14 inches or so away from a piece of paper on the wall, and they covered one eye, and they mapped out their physiological blind spot. And then they did that with the other eye. Okay, so in this example, you're seeing the right eye blind spot and the left eye blind spot. This is a physiological blind spot based on the optic disc. Okay, the cortical perception and thalamic relay. Now keep in mind, these people came in with upper cervical subluxations. So they had some messed up nerve communication to their eyes because of the rotations and translations and all that of the bone. Okay, so here it is again. Before they were manipulated on cervical number 2, the right eye had this big physiological blind spot, and the left eye had this small one. And this was their focal point, meaning where the patient was originally looking while they mapped out their blind spot. Okay, then they adjusted them, moved the bone back into place, got the nerves firing better. Then they post-checked them. The physiological blind spot improved drastically. So this one was normal. So everybody has a physiological blind spot. But some people, because of certain issues, the nerves aren't quite firing right and communicating accurately. So vision is a little bit off. So there's your evidence of that. You correct it, and then it goes back to normal. This is what we want. So yes, adjustments do work. Let's go back to our article we talked about first week of class. If you mess with your spine, you mess with the nerves and the spinal cord and afferent, efferent, and all that, and function goes down. It just does. When you get it corrected, when you practice spinal hygiene, and you take care of yourself, function goes up. Quality of life goes up. And you want to age into that. You don't want to wait till you're old and already degenerated and arthritic and decrepit and then try to take care of yourself. Do it now while you're young. Okay, night blindness is when the rods are not working properly, usually because of prolonged deficiency of vitamin A. Okay, vitamin A is a fat-soluble vitamin. Fat-soluble vitamins on a busted gut, and what I mean is a lot of people have an irritated gut. They have gut inflammation, they have leaky gut, they're pro-inflammatory diets, and on it goes. So they have a hard time absorbing and assimilating their fat-soluble vitamins, which are vitamin A, D, E, and K. There's a complicated process and a huge cascade of events that your body does to break down the fat-soluble vitamins in order to get them into your system. And unfortunately, a lot of people have a busted gut, so they can't really do that properly. So there's quite a significant deficiency in either or one or more of the following: A, D as in Delta, E as in Echo, and K, A, D, E, and K. So a vitamin A deficiency usually leads to deterioration of much of the neural retina, as in vitamin A is the building block for the pigment of the photoreceptor cells needed to respond to light. And vitamin A can restore function provided degeneration or you have not crossed the point of no return. Now I give my patients miscellized and emulsified vitamin A, and I give them that on purpose because if you miscellulose, the body is supposed to miscellize and emulsify the fat-soluble vitamin for you. But because I know most people have a busted gut and they don't have that function, I give them a high-end vitamin A that the manufacturer already did that for you. They miscellized and emulsified it for you, so when you take it, it gets right into your system, and you don't have to worry about it. Now, granted, we still work on diet and lifestyle stuff, but at that point, my concern is getting them a quality vitamin A that's going to get in their system irrespective of their current lifestyle. Okay, the fovea centralis is a tiny pit that contains only cones. It is the area of greatest visual acuity or sharp vision. So this is where you do your critical viewing, and the critical viewing images are brought into focus there. And our eyes are sensitive to the wavelengths of visible light, the blue light, the green light, and the range of green and red wavelengths. Now let me make a comment on the blue light. I don't know if you noticed, but the screen just changed colors. And so I have my computer set to blue light filter after a certain time of day. And I do that on purpose because blue light, which is emitted from computers, tablets, smartphones, the exposure to blue light that comes off of those screens stimulates your brain to stay awake. It inhibits the sleep-wake cycles, or I should say the sleep cycles. It inhibits it, keeps you active. So a lot of people who have problems sleeping at night or falling asleep at night, I manage a lot of those cases. People come in looking for naturopathic remedies to help them sleep, to decrease stress, that kind of thing. There's many techniques that can be done naturally to help people sleep. So here's a quick version. In no particular order, you want to manage your stress. So we talk about that, and we talk about diet and lifestyle, bouts of exercise, and making sure the foods that they're eating are not artificial and these stimulants that can keep them awake and pro-inflammatory and so forth. So we get into all that. And we also get into exposure to blue light. And I also know that they likely have a deficiency in serotonin and melatonin, which means they have a tryptophan metabolism problem, which is a gut issue. So we talk about that, and we just get into some of these behind-the-scenes techniques that I already know people do because it's just our culture. Culturally speaking, we're all stressed out, we're overexposed to electronics, we watch TV before we go to bed, and on and on and on it goes. So we dive into techniques that start to minimize hurting the brain's area of preparing for sleep. And one of them is blue light. And on your phone and on certain tablets and all that, you can download an app. Just simply type in the keywords blue light filter and click the one that you feel is best for you. And then once you get it and you turn it on, you'll notice your screen turns kind of a red tintish color. Okay, it takes away the blue light, which is good because now you're not getting that stimulation from blue light, which means your brain can actually start to prepare for sleep. Now, this technique applies at the end of the day. You don't have to do this at noon or during the middle of the day, because blue light is fine during the middle of the day. But when you don't want to be exposed to it is after the sun goes down. So in the wintertime, that's around 5 p.m. In the summertime, it's 8, 9 p.m. or whatever. So you pretty much try to follow the patterns of sundown. So once it starts getting dusk, just practice your blue light filter stuff. You can also get glasses that have the blue light filter built into the lens. If you wear a corrective prescription strength lens, you can have that added into the lens. And if you don't wear prescription glasses, they still make regular glasses that have the filter. And if you don't have the capability of doing an app, then you can buy a blue light filter screen that goes over your computer. Okay, so here's some pictures of the bipolar nerve. So they're showing you the back of the eye, the retina area where our photoreceptors are found. And they're showing now a magnification of the choroid. So we looked at the choroid plexus earlier, and there's the pigmented layer, the pigmented cells with the bipolar neurons. Now here's the cones. In this animation, the red ones are the cones and the blue ones are the rods. Okay, and they typically alternate. Then after that, they synapse on the bipolar cells, that synapse on the ganglion that communicate to optic nerve, that send it to the optic chiasm and optic radiation back to the occipital lobe. Okay, just another picture showing you the rods and cones coming in and the light coming in and synapsing, which is stimulating them to work, to tell them to do their job. Another picture, the same thing. So here's cranial nerve 2 with the blood vessels coming in. Okay, right in here you're seeing the rods and cones, and when they magnify it, you're seeing the choroid, the pigmented layer, and then the rods and cones, the bipolar nerves, the ganglion, and cranial nerve 2. Okay, with the lens, when light enters the eye, it's focused on the retina. And I also posted a video of the corrective lens concept, why some people need glasses and others don't, and what's going on. So I have a really good video that explains that. So please watch that. The lens is held by the suspensory ligaments and the ciliary zonules that are attached to the ciliary bodies. And we looked at that on a prior slide. The lens divides the eye into the anterior and posterior parts. The anterior part we find the aqueous humor, and the posterior part we find the vitreous humor. The humor keeps the eye from collapsing. It maintains integrity, intraocular pressure in a healthy way. Now, intraocular pressure can get nasty, like with diabetics, or other conditions, high blood pressure, and so forth. And also the humor provides nutrients to the lens and cornea. Because they lack a blood supply, the humor supplies those nutrients. So eye circulation is very important. Okay, so I do have some patients that we work on eye circulation, and it has dramatically helped them. Okay, glaucoma is the result of poor aqueous humor drainage. Now back to that canal of Schlemm that we looked at. Most of those people, that canal is blocked, so they get this buildup. Now, unfortunately, medically, they just typically do like eye drops, and they'll do steroid drops and things like that, which is fine. But I also like to add the manual work to the eyeball itself to get the drainage moving again. Pressure within the eye increases and begins to compress the delicate retina and the optic nerve, and so that's where the damage begins. I mean, this is no different than taking a tourniquet and just starting to gradually tighten it around your arm, and just gradually tighten it and gradually tighten it over time. And what you're doing is you're just slowly cutting off the circulation and life to everything from that point down. That's what's going on in the eye. So my job is to undo the tourniquet so circulation can come back. And that's the key to this, is circulation, circulation, circulation. The other thing that helps is nutrition, 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 and lifestyle, lifestyle, lifestyle. Once you start getting all those in order, especially if you catch it early, it can start to reverse itself. And I've gotten numerous results of that with some of my patients. And they get their follow-up with their eye doctor. So this isn't just something that we, just, oh, all of a sudden you're better now. No, I mean, we do the work, and then they go get post-check from their eye doctor, and they're like, what are you doing? Like, it's actually getting better. And we explain it, explain what's going on with the adjustments and the eye circulation and nutrition, aqueous and vitreous humor work. And once you do that, life starts coming back and healing can take place. So some signs and symptoms of a person that's starting to get glaucoma can be halos around the eyes, headaches, blurred vision, loss of peripheral vision. A tonometer can help to assess the pressure, like how hard or soft the eyeball is. And but there's some other options with eye drops and surgery to promote aqueous humor drainage. Okay, I do it manually and with some electric stimulation, but medically they can do it with surgery. Unfortunately, things have to get pretty bad for that to take place. In the early phases, they'll do eye drops and things like that. Of course, I like to add the manual part to it and nutrition as well. Okay, this is what the back of the eye looks like. The fundus is the posterior wall of the eye that contains the retina, the optic disc, the blood vessels, the macula, and the fovea centralis. So when you take an ophthalmoscope or a fundoscope and you look into someone's eye, this is what you should see. This is normal. Okay, so the disc, the blood vessels coming out of it, the retina, the macula, and the fovea centralis. I have looked in people's eyes and have found some really weird things going on. A detached retina, a bulging disc. You can tell that the circulation is very poor, so stuff like that. I'll send them out. I'm like, I want you to get an exam by an eye doctor. Let's see what's going on. And then based on the results will depend on the treatment plan. Okay, when light enters the eye, it is bent by the lens or refracted by the lens. The whole point is to focus the light on the back of the eye, on the retina, on the focal point. So the greater the lens convexity or the bulge, the more the light will bend, as you can see down here. This lens is bulging more than that one. So there's greater bending of light. The flatter the lens, the less it'll bend light. Okay, so up here you're looking at something far away. The eye's more relaxed when you're looking at something far away. The eye is in contraction when you're looking at something up close. Okay, so this is looking at something near. When the lens bends, it's the ciliary body allowing the convexity, and this is how we see objects up close. It's called accommodation, being able to look at something far away and then immediately being able to look at something that's right in front of your face. Okay, that's called accommodation. In fact, there's a test for that. It's called the accommodation test, where you're sitting with a patient, they read something in the back of the room, and then you put like a business card in front of their face and say, what does this say? Okay, you're assessing to see if they can see far away and then see up close, if their eyes have the ability to adapt. Okay, as light is coming in, it's going to come in and hit the cornea, the iris pupil, the lens, goes back to the retina, hits cranial nerve 2, so the optic nerve, to the optic chiasm, to the optic tract, to the optic radiation, to the occipital lobe. Okay, with the eye exam, convergence is the ability of the eye to go cross-eyed. You take a pen and you hold it at a distance from them and you say, follow my pen with your eyes, and you start to travel it toward their nose. As you can imagine, their eyes will cross as they're following the pen to their nose. Accommodation, just talked about that one. And then your H test, eye movement, so your cranial nerves and your lateral rectus, superior oblique, and all the rest of the eye muscles. And then the cranial nerve 2 and 3 pen light that we've talked about. Okay, so that's part of your eye exam. You can also throw in Snellen chart. Okay, here's some fancier pictures from Netter on the sclera, the choroid, and the ciliary bodies and zonules and the lens and how they attach to it. It's kind of interesting. I mean, these are almost like tiny little tendons, tiny little strings that attach themselves to the lens. And you're seeing it here as well. So when the ciliary body contracts, which is like a little muscle, it changes the bulge of the lens. Okay, you're also seeing it here, so they're zooming in really tight. To the zonular fibers, and there's the lens there and how it connects in. It's very, very, very intimate, very delicate. It's amazing how we're designed.